Assalamu alaikum dear doctors. In this video I am discussing a video station. So first we will watch the video, then I will discuss what type of question we are expecting from this video. So the task is in this video that a 2-year-old toddler and she has fever for 2 week duration and child is unwell and very sick.
Okay. Hi, sweetie. And I'm just going to I'm going to try and capture her lips a little bit here. And then let's turn her hands over. And
yeah, because we can do 8. We've been with 8.
Okay. Now let's see the other hand. Okay. And then as far as any like swollen lymph nodes on her at all?
Not really swollen lymph nodes. The rash also goes
Let's see this rash.
from her neck all the way down to her growing area and across her stomach. The rash, like her hands, is also on her feet.
Yeah. Okay, so it's kind of a fine...
The back is worse than the stomach.
papular tire rash. It's not really elevated. Okay, let me see our other foot too. Hey, sweetie. All right, and let's take a look at her back then. Really appreciate you letting us. Okay, all right. It's definitely not like a strep throat rash. Now let me just palpate. Let me just palpate for lymph nodes on her too. She has some shoddy little lymph nodes, I think. Shoddy means basically it's a term which I'm going to try and come around with my other hand to the front here.
She's also had the swollen eyes.
Yeah, that's right. She's got some, I think, little lymph nodes, but they're not real dominant. But so what's going on with her eyes?
Running pus and swelling shut.
Okay.
Every once in a while.
Okay. Let me just pull the eyelid down just a little bit. Kind of reddish looking in there. You see some dried stuff around there. Okay. All right. Now let's see if I can just get a look at her mouth real fast. I just want to pull your lips down. Maybe Mom could do that. Could just kind of open her mouth just a little bit so we can see what's on the lips.
They're just so dry and hurt, and I don't want to hurt her.
Yeah, no, I agree. Looking up underneath there. I see the corners cracked over there. Okay. You were a trooper. Thank you guys for...
First question is that what I observe in this video. I can see a video of a 2-year-old child. She has fever and she is in hospital setting looking unwell but alert. She has no any dysmorphic features and no any devices attached. I also see that her lips are red and bit of cracks. There is red palms and soles and rash on the trunk and also a scar mark below the nipple. So from all the features, the main diagnosis on top is Kawasaki disease, as the features are supporting, and the differential diagnosis can be scarlet fever, measles, COVID, PIMS, rubella, roseola infantum, anaphylaxis, and drug reaction. Question is that what history I would like to ask in this patient. So I'd like to ask number 1, the onset of rash distribution, where start fast, is it painful, itchy, elevated on the surface. Number 2, any other family member has the same rash. Number 3, fever for how many days. Number 4, erythema at the site of BCG mark. Number 5, any eye redness and if associated with purulent discharge or not. The number 6, any neck swelling present or not. Number 7, any mouth redness or oral soreness. Number 8, any edema or peeling in fingers and toes. Number 9, any chest pain or palpitation. And number 10, question for the differential diagnosis, we'll ask the history. Now, next question, what examination we'd like to do in this patient. So I'd like to do ABC, that is airway, breathing and circulations. Then vitals, special the heart rate and hydration status. I will do the cardiac examinations. And examination of rash with glass test, that is blanchable or not blanchable. Then cervical lymphadenopathy examinations and other lymph node and eye examinations. Examination of the BCG site, that is indurated or not. Next question, what investigation I would like to do? So the investigation, none is diagnostic. I would like to do the full blood count, ESR, CRP, liver function test and albumin level. Urine, sterile pyuria, CSF lymphocytosis, culture urine blood, ASO2 and throat swab. Then virology screen if rash persists, the enterovirus, parvovirus, Epstein-Barr virus, cytomegalovirus, measles and PCR. ECG, ST depression, T-wave inversion, HB. And echo, do not delay therapy before echo. Question about the management of the Kawasaki disease. First, aspirin. Aspirin is 7.5 to 12.5 milligram per kg 6 hour until febrile or minimum 2 weeks to be decreased to 2 to 5 milligram per kg OD for 6 weeks. Then IV immunoglobulin we give, that is 2 gram per kg, monitor respiratory rate, heart rate and blood pressure. Take care of allergy, given gradually, can be repeated if fever persists 36 hours after one first dose. Then monitoring the IV immunoglobulin infusion. That is monitor temperature, heart rate, blood pressure and respiratory rate every 5 minutes for first 15 minutes. Then every 15 minutes for first hour. Anticipate anaphylaxis, flushing, fever, headache, shivering. If tolerated, increase the infusion rate to give total dose over remaining 10 hours and monitor hourly. If a mild reaction, stop infusion for 15 minutes, then restart at slower rate. Methylprednisolone. So methylprednisolone, that is doses 0.8 mg per kg per 12 hourly for 5 to 7 days or until CRP normalize. After discussion with rheumatology, given in high risk patient or if fever persists after second dose of IV immunoglobulin. Followed by prednisolone 2 mg per kg per day, weaned over 2 to 3 weeks. Then infliximab. After discussion with the pediatric rheumatology, given in case of methylprednisolone failure. Discharge and follow-up, that is when fever settled, echo at 2 weeks and 6 weeks from onset of sign and symptoms. Outpatient management is that no aneurysm at 6 week echo, stop aspirin and no restriction of activity and follow-up after 1 year. Single aneurysm less than 8 mm, then aspirin 2 to 5 mg per kg till aneurysm disappears. Activity level is determined by cardiologist and follow-up every 6 months with ECG and echo. Then multiple or giant aneurysm or steroids, lifelong aspirin and warfarin. Advice. What advice we give? Avoid excessive exercise till echo is appointment. Avoid all live vaccine. Live attenuate vaccine 3 months after the IV immunoglobulin. Then when to seek advice from pediatric rheumatology. If incomplete Kawasaki, feature suggestive of alternative rheumatological or inflammatory diagnosis. Age less than 1 year, failed first dose of IV immunoglobulin. Now next question is that the high risk factors. So high risk factors for Kawasaki disease are age less than 1 year, shock, coronary or peripheral aneurysm features, failed IV immunoglobulin, persistent increase of CRP despite IV immunoglobulin, liver dysfunction, hypoalbuminemia and Kobayashi score is more than 5. Now what is complete Kawasaki disease? That is fever for 5 days or more plus 4 of the following features. These are conjunctivitis, bilateral non-purulent, oral changes, red lips, pharynx and tongue, peripheral edema, that is erythema of palms and soles, followed by desquamation 10 to 14 days, rash, that is polymorphous with no vesicular, no crust, lymph node, that is acutely enlarged cervical lymph nodes more than 1.5 cm. Next question, what is incomplete Kawasaki disease? So incomplete Kawasaki disease is children with fever equal or more than 5 days plus 2 or 3 criteria, then infant with fever more than 7 days plus other explanation. CRP less than 30 and ESR less than 40. If fever persists, serial lab and clinical follow-up. If peeling, then echo will do. CRP equal or more than 30 and ESR equal or more than 40. Treat if anemia, platelet more than or equal 45, 4,50,000. That after day 7 fever and WBC more than 15,000. Elevated ALT, albumin is less than 30 gram per liter. Urine equal or more than 10,000 WBC per microliter. So next, what is atypical Kawasaki disease? So atypical Kawasaki disease may not fulfill all the above criteria. If fever less than 5 days but 4 signs above and persistent elevation of CRP, no other diagnosis and suspicion of Kawasaki disease. Fever usually precedes the other signs unresponsive to antibiotics. Common features, that is irritability, erythema of BCG site. Other features are aseptic meningitis, uveitis, cough, vomiting, diarrhea, abdominal pain, urethritis, arthritis, examine for aneurysms in other areas, example, axillary. So this is Kawasaki disease. Kawasaki disease is very important. It comes commonly on exam. Now I am again another disease, that is pediatric inflammatory multisystem syndrome, PIMS, discussing. PIMS same as Kawasaki, there is blanchable rash with picture of sepsis and multi-organ affection. So investigation we do for PIMS, full septic screening, LDH, D-dimer, ferritin, clotting with fibrinogen, COVID, PCR. Common blood abnormalities, none is diagnostic. Lymphopenia, neutrophilia, elevated platelet, raised CRP, raised ESR, low albumin, raised ALT, raised D-dimer, elevated troponin and pro-BNP. ECG, there is variable features including ischemia and echo where available normal. Impaired function, coronary artery abnormalities. If respiratory symptoms, then we do chest X-ray. If abdominal pain or abnormalities on examination, so abdominal ultrasound. Management of PIMS is appropriate PPE and standard APLS resuscitation. Then broad spectrum antibiotics, that is cefotaxime, clindamycin if feature of toxic shock. Long-term outcomes are not fully known. Outcomes for patients have been favorable to date. So this is all about Kawasaki and PIMS. Please do subscribe and share MRCPCH with Dr. Emma Chaudhuri. Thank you.